Welcome, welcome, welcome. Welcome back to the elbow and the forearm. Can't wait to get started. Let's get it going. Let's look at the relative structure and function of the elbow and forearm, and I think figure 18.1 actually does a really good job of showing you those things. But when we kind of look at the elbow and the forearm, we can kind of break it down into the humero ulnar articulation, right? The humerus and the ulna. And what that's going to do is that's going to give us our carrying angle. So if you put your arms down by your side and you bring your humerus as close to your body as you can, you'll notice that your forearm kind of deviates out to the side, or kind of puts you in a little bit of elbow valgus, if you will. And so what that we're looking for is just based on kind of anatomy, you can have a larger carrying angle than somebody else. And so that is basically developed from the axis of rotation is slightly superior from the medial to lateral due to the distal elongation of the trochlea. So the trochlea is a little bit longer on one side, and that causes us to have a little bit of ulnar deviation laterally compared to the humerus when our elbow is in extension. So again, is that kind of anatomical change that kind of puts us to have a larger carrying angle than the other. And the reason that's kind of important is we just know that the larger carrying angle you have, we have seen some correlation with increased elbow injuries. It makes sense if my elbow isn't quote quite straight from the position when I load it, and it's loaded in that kind of valgus position, it can potentially lead to more problems. Nice thing about the elbow is it's got a ton of ligaments, and the reason it has a ton of ligaments is because it's looking for stabilization. But this is what I was kind of talking about with the carrying angle. Again, you'll kind of see here in this picture that this person has a relatively small carrying angle. That'd be normal. Somebody has a little bit more cubitus, that means elbow, valgus, right? That's that dive out to the side. We see that in the knee a lot. This person tends to have a little bit more injuries to the medial side of the elbow because we already have it there. And you can also have cubitus varus, which means it goes away away from that deviation next to a little bit straighter arm. And so depending on what we have, we can be a little more risk of injury or not. And then we know there's also the humeroradial articulation, so humerus and the radius. And then we know we have lots and lots and lots of ligaments that are nice and strong, so the elbow is nice and stable. So you can look at the figures in the book that will kind of outline these a little bit more specifically for you. And here's just an example of how many ligaments you got that are going on and where all the tendon attachments are. So fortunately you guys already had anatomy. We don't have to review this for too much, but take a look at the picture if you need. So as we move to the arthrokinematics of the elbow, when we look at the proximal radial ulnar articulation, so this is the radius articulating with the ulna, not the radius with the humerus, or the ulna with the humerus. So at that proximal radial ulnar joint, we're really looking at the motions we're going to see is pronation and supination. So when we kind of look at the bony articulation here, we notice that we have a convex rim of the radial head articulating with a concave notch on the ulna. So then that means that as the forearm rotates into pronation, the rim of that radial head rolls and glides opposite, right, because it's convex on concave. So with pronation, that radial head rolls anteriorly, or volarly in this case, and glides posteriorly, or dorsally, compared to the radial notch that's on the ulna. And when with supination, it's the reverse of that. So when you're thinking of the radial ulna joint, you got to remember that we're not looking at the radius in the humerus or the ulna in the humerus. We're looking at the articulation between those two bones. And then distally, when we look at the distal radial ulnar joint, so down as we get more towards the wrist, we have the concave ulnar notch on the distal radius articulates with the convex notch of the head on the ulna. So the ulna becomes the convex and the radius becomes the concave. So we're still going to see mostly pronation and supination with this at the end of this joint. And so basically how this one works is as the forearm rotates, the concave radius glides in the same direction as the physiological motion. So it glides anteriorly or volarly with pronation and glides posteriorly or dorsal with supination. And why this is important is because after an elbow fracture or after some immobilization of the elbow, and we're trying to get back pronation and supination, which is very helpful in function, is we can utilize that knowing that if we're going to be at the distal radial ulnar articulation, we need to mobilize in the same direction. And if we're at the proximal, we need to mobilize in the opposite direction. So you can use that to your advantage when we look at the joint mechanics and doing joint mobilizations. When we look at the actions at the elbow, basically in the forearm, basically at the elbow we know there's a lot of flexion and extension, and then there's forearm, we got supination and pronation. So now you got to think about what muscles will kind of act on each of these things. When we look at elbow flexion, we know that the brachialis, the biceps brachii, and the brachioradialis are really helpful in elbow flexion. The bicep brachii has the greatest amount of contraction in the 80 to 100 degrees of motion. And the reason for that is we're looking at the length-tension relationships. That's the only one that crosses over the shoulder as well. The brachioradialis, that one really helps provide compression and stability. So it's the primary elbow flexor during rapid movements, and it's supinate. It's one of those ones that kind of reverses. We talked about this with kind of your piriformis and your glute medius, depending on where the range of motion is, it could become, instead of being an external rotator, it could become an internal rotator based on the line of pull. And so the brachioradialis is one of those other ones that kind of do this. So when the arm is actually in supination, your brachialis, when it contracts, will create pronation. However, if your arm is already in pronation, when the brachioradialis contracts, it will become a supinator. So it's really interesting to be able to utilize that principle when you're coming to rehabbing somebody. We know with elbow extension, we're looking at the triceps. And remember, with the triceps, it's attaching only to the ulna, so you're not gonna see any forearm pronation or supination with tricep extension, whereas you would see some supination with biceps brachii. And then you have the anconeus, and remember that one's a really small muscle, so its main goal is to kind of help stabilize the elbow during extension activities, and it can also help with a little bit of supination and pronation. When you're doing active supination, most of that's going to really come from your supinator that you have, and then the biceps brachii will also supinate if the elbow flexes simultaneously, or during kind of like moderate to higher power level activities, the supination occurs when the elbow is flexed to 90 degrees. And then we also mentioned that the brachioradialis can become a supinator if you were in pronation and we're kind of doing those higher power motions. And then with forearm pronation, we have a pronator teres, we have a pronator quadratus, and the pronator quadratus is really helpful to create that compression for stability. So we have a lot of ligamental stability here, and we have a lot of muscles that kind of also, when they contract, help create stability even more. When we look at the relationship of the wrist and hand muscles to the elbow, we know if you just kind of took a basic generic view and could take your skin off and look at your muscles, we know that the wrist flexor muscles, most of those are going to attach to the medial elbow. Remember, you got to think of it from an anatomical position as well, that medial elbow. So we're looking at flexor carpi radialis, flexor carpi ulnaris, palmaris longus, flexor digitorum superficialis, flexor digitorum profundus. Remember all those muscles? Yeah, you got to remember them. If you kind of forgotten, take a look in your book. And the reason those are important because those muscles will if they become injured, can reproduce medial elbow pain. And there's a difference between medial elbow pain and there's a difference between lateral elbow pain. Sometimes people call the medial elbow pain, if it's kind of a strain, we'll get to it later on, more of that golfer's elbow, versus the lateral side ends up being more of that tennis elbow. And when we look at the wrist extensors, we know that's actually on the lateral side. So you can imagine that if somebody's having tennis elbow, usually that's an indication that the wrist extensors are having some problem. For somebody having this golfer's elbow, usually it's more of those wrist flexors are being there. And so when you're looking at your wrist extensors, don't forget it's your extensor carpi radialis longus and brevis, extensor carpi ulnaris, extensor digitorum. Chapter 19, I know we're in 18, but chapter 19 again has a lot of the functions of the wrist and hand, and we'll dive a little bit more into those muscles if you need a quick review. Now we're going to get into the referred pain and nerve injury of the elbow region. So, a common source of referred pain into the elbow comes from the cervical region. And the reason for that, we know, is because a lot of the nerves that are coming into the arm begin in the cervical spine and then work their way down to the hand. So whenever we have somebody that has elbow pain, we always have to make sure we're looking up the chain further to make sure we can't do that. And by do that, I mean reproduce their pain. So remember, referred pain would be this person's complaining of elbow pain. I come up to their neck and I move their neck, or they move their neck, and it recreates their elbow pain, that exact pain. That would be what we considered referred pain. And not just my elbow hurts and then I have them move their head and they're like, oh, that hurts my neck. Was that the pain you're seeing me for? No. Well, that's not really the referred pain we're kind of talking about at that point. Then we can have nerve disorders in the elbow itself. And so this is when you kind of hear those things called like nerve entrapment injuries, where something or some structure is kind of pressing on the nerve. And if you recall with your anatomy, nerves tend to do this thing where they kind of dive below some things and go between certain things and go over top certain things. And so sometimes whenever they dive under something or whenever they're going through something, those always become areas that they could potentially become entrapped. And then if that nerve gets entrapped, it will reproduce symptoms along that nerve distribution. So you guys have all felt this before, like if you hit your funny bone on anything and you get that nice numbness and tingling down into your little finger and your ring finger, well, you basically hit your ulnar nerve because that runs right through that cubital tunnel. So that's one area of entrapment. So if a patient's complaining of numbness and tingling in the hand, and I can come right to that funny bone, if I tap on that nerve there and it reproduces their same pain, then I know that's a cubital tunnel entrapment of that ulnar nerve, and I have to treat it accordingly. Another site of compression for the ulnar nerve would be between the two heads of the flexor carpi ulnaris. So you kind of have to be able to track your anatomy and track your nerves as it runs through anatomy. So a really good idea of 3D structures. So here's kind of the path of that ulnar nerve, and again you'll notice that it kind of runs down through here, and this will be where that cubital tunnel starts to happen through here. And then we have our flexor carpi ulnaris muscles, and you can see it's running right between those two. So sometimes if that gets compressed down too much, you can pinch on that nerve and you'll get a little bit of symptoms there. If we look at the radial nerve, right, so radial nerve is going to do a little bit more of the extensors that you have. So we know that the radial nerve under the extensor carpi radialis brevis is a really good place. Arcata frost is another one, and then you can also have the distal edge of the supinator. All three of those are one of the more common areas that you could see the radial nerve entrapment. And so what that would look like here is this. It runs a little bit differently. So the radial nerve in this picture is on the left side of the screen. The right side would be more of your median nerve. And so you have a couple different areas here, and you'll see where the arcata frost is just basically where things dive. It's just somebody wanted to put a name of something, and I'm sure Dr. Ted has a better explanation of why they call it that in particular. But there's just along that path, those are the areas that you may find you can get a radial nerve entrapment. With median nerve, we know the most common spots are the pronator teres, the ligamentous sutures, the bicipital aponeurosis, and the deep flexor digitorum superficialis. So you can see that there's a whole bunch of areas that there's potential entrapment. And so for me as the physical therapist, what that means is if I think this is a ulnar nerve issue, you guys know from anatomy what muscles are innervated by each of these nerves. You know what the general distribution is. Remember, these are not dermatomal patterns that would come from the cervical spine. These are just along the roots of these nerves, so you have to be able to differentiate those two. But then based on what muscles are weak or what sensations that they're not having, what fingers are kind of being numbed or tingled up, if you will, that kind of gives me an idea of which nerve I think is entrapped, and then my job is I have to go figure out where this would be, where they could potentially become entrapped, and we'll show you some tests when you get to MSK next year about how you can go through and figure out where these are. Hint, hint, your palpation skills are going to come in very much of a good tool for you to have, so keep practicing to the best of your ability. And here's kind of the things that we're talking about. So up here, we're seeing this is the ligamentous sutures, and then you have your pronator teres compression spot through there. So there's a few other spots that you can kind of have. Moving on to kind of the management of the elbow and forearm disorders and surgeries. Nice thing about this part is, the shoulder was we know is a very long podcast. I'm sorry, it's a long chapter. It's hard. People get whole weekend courses for that. I got 100 pages in the book to get through. The elbow is not nearly as complicated as the shoulder is because we don't have as much motion going on. It's usually more of a stable place with all those ligaments and all those muscles creating more stabilization. But a lot of the surgeries, the principles still kind of match up with what we had seen before. So some pathologies, and that may lead to hypomobility. We've kind of already talked about these. We could have rheumatoid arthritis. We could have juvenile rheumatoid arthritis. We could have osteoarthritis. We could have immobilization from a fracture or dislocation and having that period of immobilization. Those are some of the more common reasons that someone would have elbow hypomobility. And then basically we know that in the acute phase or the acute stage, the impairment is going to be effusion, pain, muscle guarding. We know in the subacute phase, the symptoms and the impairments are going to be more of a capsular pattern, which for the elbow, it means that elbow flexion is more restricted than elbow extension. And you may or may not have restricted pronation and supination. The capsule and around the elbow really affects more flexion and extension. And then some of the common activity limitations and participation restrictions. Well, think of all the things you use your elbow for, not just flexion and extension, but also rotation. So twisting doorknobs, pushing and pulling activities, feeding yourself, grooming yourself, using a telephone, trying to carry things like groceries, reaching to get different things. All those are going to be influenced by having some increased elbow pain or hypomobility. So what do? It's nice when we keep running into the same thing over and over, right? First we go into the protection phase. Well, what do? We educate the patient. We teach them about we teach them about inflammation. We teach them about immobilization. We teach them about protecting and maintaining the integrity to the best of our abilities. And so what are the things we need to do? We need to treat pain. We need to treat muscle guarding. We need to treat swelling. Grade 1, grade 2 mobilizations, passive range of motion, active assistive range of motion, our gentle isometrics, ice, compression, elevation. You guys know all this stuff now. So the nice part is it keeps showing up through here. We know we need to maintain that soft tissue integrity to the best of our ability. Use those isometrics. Put the area of concern in the appropriate position. If it needs to be protected in a shortened position, put it there. If it can be a little more elongated, put it there. Wherever you need to go to make sure that we're promoting a healing environment. And we have to maintain the integrity and function of the related areas. So even though we're working on the elbow, maybe that's immobilized, maybe we're still doing things at the wrist because we know that those muscles go all the way up to the elbow. Or maybe we're working on the shoulder to make sure we turn a stiff elbow into a stiff shoulder as well, within the guidelines of what you can. So always try to maintain things to the best of your ability as long as it doesn't compromise the protection you're trying to get for the patient. So kind of moving on again, sticking with the non-operative management for somebody with joint hypomobility, when we get to the controlled motion phase, that's when we can start to work on the tissue flexibility a little bit more. Maybe we're getting into more of those grade 3, grade 4 joint mopes to kind of get some of that motion back. Maybe we're improving joint tracking. That's some of the mobilizations with movement with the belt. We'll kind of actually show you some of those things in lab that we'll get to. We need to improve muscle performance and functional abilities. So we know that these are all the main goals we've seen multiple times for the controlled motion phase. You just have to remember that when with the elbow, it kind of flexes and extends and and then the forearm does more the pronation and supination. So for stretching, mobilizations, etc., if you're really trying to get terminal elbow ranges of flexion and extension, you may actually have to emphasize the accessory motions of, as we know, as we go into elbow extension, I need a little bit of ulnar valgus because that's that carrying it. We gotta work on that. And as I go into flexion, I'm actually going to get a little bit of like arm varus, and so it's kind of knowing that it's not just straight up and straight down. It's down and out to the side, and then up and towards the body is what you're looking for. So if we're missing elbow extension, remember the radius doesn't really have an articulation with the humerus. Is that, remember, you got that radial head that's nice and circular, doesn't actually have a contact point with the humerus. So if we're missing extension, we're really focused on the ulnar side. If we're going to do some mobilizations, we're going to do it to the ulna. And if we're missing flexion, now we can add in the radial side to get the flexion part as well, as long as with it, in addition to doing it with the ulna. And then remember, here you got to note what your end feels are. If it's hard, which is supposed to be the normal end feel for elbow extension, you can't stretch that. But if somebody had a fracture, let's say, and you're trying to improve elbow flexion, and you bend them up and you do active is limited, passive is limited, and when you do your end feel assessment, you feel a hard end feel in elbow flexion. Well, that's not normal. And if you need to go get them an x-ray to figure out what's going on, and because if you can't stretch through a hard end feel, that's bone on bone. We need to do something different, and if that's not expected in elbow flexion, particularly in a limited range, we're in trouble. Maybe there's something that kind of happened. And the reason we kind of talk about that is what I'm talking with the elbow flexion and the hard end feel is you can get something that looks like this. Like if it's traumatic, like this person fell and had a fracture, is you'll notice that this is a muscle belly right here, and we got this giant thing right here. So this is actually bone forming in the muscle. So you can actually get what we call heterotopic ossification, and that's when bone shows up in soft tissues. It generally happens more from trauma, and that could be kind of a fracture or a direct blow. Like if this was a hockey player and they had a puck go right to their arm, the body can overcorrect instead of healing the muscle. It actually would create more bone because remember, you had that compression force. That puck whacked that arm at that direction that the arrow is going here. You had that compression force. The body understood that as needing to make more bone, and so it will replace the muscle with the bone. And if that's the case, if that's what happens, that this patient has to get surgery in order to get that bone removed out. There are some conservative things that people may try, and we'll get into those a little bit more. But you can see that not only on this patient are we seeing it here, we're also seeing a little bone formation here. So we're not really expecting to see that, so we have to know that as we're going through this rehab, this could potentially happen. When we get to the more end phase of rehab and that return to function phase, we already know what we got to do. We got to improve muscle performance, restore everything else we need to, and then protect the joint if we need to, right? I mean, this could be if we had a surgery that tried to stabilize the joint, maybe we make sure we're not doing anything crazy to get it unstable. If they had an elbow replacement, which we'll see in a little bit, we want to make sure we're not doing anything to compromise that as well. So when we think about getting into the surgical side of things, the most common mechanism of injury, MOI, for injury to the elbow that requires surgery is a foosh, or fall on outstretched hand. And that's really the most common thing that you'll see. And it's in adults, the most common elbow fracture tends to happen at the head and the neck of the radius, and it's approximately about a third of fractures. And it's usually because they put their hand out to catch themselves as they're falling, and they put their hand out, outstretched hand, and then you get that compressive force that goes through the arm, and then it's got to come out somewhere, and it can come out in the wrist, it can come out in the elbow, it can come out in the humerus, it can come out in the shoulder. There's a whole bunch of places it can come out. If it ends up coming out in the In the elbow, it's usually that head and neck of the radius. And the indications for surgery. So, what are some other reasons other than just a traumatic thing and a fracture that I I may need a elbow surgery? Well, that'd be kind of similar to some of the other things we saw with the shoulder. If it's pain that's uncontrollable, if it's too lax, there's not enough stability. Maybe I need to stabilize it down more. Maybe I have limited range of motion because you have that bone growth in there and they needed to remove that, or you have a severe osteoarthritis and they want to open the space up more to allow your shoulder or your elbow to move more, or surgeries that require just for improved function. And when we kind of look at the outcomes across all these things, we know that if the surgery is for more pain relief or stability, those tend to have better outcomes than those that need them for mobility. That's just kind of where we are right now. Is we're pretty good at stabilizing it down, but not as good as restoring all the motion that it used to have. And we also know that trying to push more and more mobility of a joint that's supposed to be relatively stable, right? We had all those ligaments and muscles doing everything. We're kind of taking away what the point is of that joint, and that could be potentially why we're seeing not as good of outcomes there. And there's a ton of procedures that you can kind of get for an elbow um, surgery, and we kind of saw a lot of them already in the shoulder, but just to kind of remind you, you can have an ORIF, an open reduction internal fixation. That's when they go in and put rods or screws or plates. You can have fixations. You can take off some of the radial head. Excision, right? Excision of the radial head. Reason I would do that, if you had a severely comminuted and non-reducible or unstable fracture, that would be a reason you go in there and it's never going to heal together, so let's just take it out. The problem with that would be that you now are missing some bone that used to be there, so it's actually going to increase your valgus deformity. You don't have that radial head to keep the arm from drifting into valgus, and so it's pros and cons as you go through there. You could take out fragments of the radial head. You could do a joint replacement of the radial head, so arthro joint, right, plasty of the radial head, and usually that's indicated for more of displaced comminuted fractures of the radial head, or if the neck is too unstable to fit with an ORIF kind of position. Your book does a really good job of explaining why you would choose one over the other. So just note that there's main thing with this is usually the indications are I can't get this pain down. I need to stabilize my joint more. We're not as good, but we can do surgeries if we're trying to improve range of motion. And then it kind of goes through all those the surgeries. Which type of tissue is involved will depend on what surgery is done. Was this an open procedure? We know there's a lot of tissues. Was this arthroscopic? Less tissues involved. Was anything excised or just taken out? Probably a shorter healing time. Were things repaired and reconstructed? Much longer healing time. So we have to take those into consideration as we're considering our plan of care. So diving in a little more to some of these things, that radial head excision or arthroplasty, some of the reasons that we would do that was mostly you got a bunch of pieces of a fracture or dislocations and you can't stabilize them anymore. There's not enough pieces to put things together and to hold them together with screws. And so times that this would be kind of contraindicated. If you had a kid who was still growing, that would be a reason that you would not want to do that. Or you're going to kind of mess up that growth plate a little bit. If you have that, you can't do an excision, and you need to have a replacement of the radial head. Otherwise, you're going to have so much elbow instability, it's crazy. So with the procedure, how it ends up going is, am I going to excision? Am I going to just take something out? Or am I going to implant? Am I going to take something out and put something back? With the excision, we know that we're taking part of that bone out, and so we're going to change basically the anatomy of what's there. So we're going to have altered kinematics, and we're going to have decreased stability because we've made the joint allowed to move more. With the implant, if I can go in there and put some cement or put some cadaver bone or something to kind of restore that, we're going to try to restore the stability that comes from that, and also trying to restore the normal kinematics. It's not always something that's an option, because we know that with implants, there's a lot of consideration you have to go into. What's the quality of tissue in there? We can have anything that gets rejected. We have to watch all those things. And With some of the complications, we know we kind of went in around the elbow. We cut through some things, so we could have some nerve damage, and we can get some posterior interosseous nerve damage. We may miss the position, may not heal in the right spot, so you can have malpositioning. You can have humeral radial instability, right? If they go in and they take that radial head out and then they don't replace it with anything, then there's this giant gap creating more instability. Anytime we go in the joint and change those things, basically we just know that our osteoarthritis is coming. And unfortunately, as soon as we go in and do stuff, within about 10 years, the patient will start to develop some osteoarthritis. And we can also start making them move too quickly, right? We know after we do stuff, there's usually a small period of immobilization. If with an implant, we know there's going to be a larger period of immobilization, but if we start moving them or the patient starts moving himself too soon, we can actually have that implant loosening, and that can lead to problems down the road. With the post-operative management, we're kind of following our normal guidelines. We have the protection phase, then we have the controlled phase, and then we have the return to sport phase. And the timelines of those are just going to vary based on what kind of surgery, how much tissue is involved, were things reconstructed, is this muscle versus bone versus ligament. Now, you guys have heard me talk about these things before, so I don't feel like I have to beat you up on there. And what are kind of the outcomes from the surgery? Well, generally, again, they're going in, they're taking out part of the radial head here for that radial head excision, or they're trying to do a small implant, which sometimes is not quite the same length as what was taken out. So there's generally a slight increase in that carrying angle at about 5 to 10 degrees, and you're generally going to have more of that valgus laxity because of that. So just like we saw with the shoulder, these aren't nearly as common, but you may see some of these if, depending on where you work. We can actually replace the elbows. We can have a total elbow arthroplasty. So total being that you're replacing both ends. You're replacing the humerus and you're replacing the ulnar ends, versus a hemi would be one side or the other. Why would a patient have to get this? Well, we know that rheumatoid arthritis is a way that would affect the elbow. Remember, rheumatoid arthritis, when you have that active inflammation, kind of swells up, starts to degrade the ligaments that are there. We know that the whole point of the elbow is to be stable. If those start to degrade the ligaments, you're going to have a lot of laxity, which can lead to a lot of pain. So patients that have rheumatoid arthritis towards more severe stages may need this. Patients that have the end stage of osteoarthritis, if things are so closed down and bone is touching each other, this may be a reason that they may benefit from that. Bony tumors, right? We know if somebody has some cancerous spot in their bone, they can go in and remove that and then replace it with the metal to try to regain the function. And then if somebody's over the age of 65, if they had any of these things with relatively low physical demands, if pain is their main problem. And the reason we want low physical demands is because you just replace something that was supposed to be really stable, right? So they have all these ligaments that are there in our natural anatomy, and then when you go in and take and do a joint replacement like this, you cut through all those things, and they're not going to grow back. So you basically way lessen the stability of that elbow. So if you try to get back to doing high level stuff, you don't have your elbow will not be able to hold together, if you will. The only thing that's holding your elbow together is basically the bone that has grown around the metal. So what I kind of mean by that is this is what it will look like, where you have some bone here that has the stem, and then you have your bone here with the stem. So that's what's creating your stability. But you'll notice that all the ligaments that were around the elbow, they're pretty much gone. They spare as many as they can, but if you're replacing the elbow joint, so you're replacing really the humerus and the ulnar portion, any of those humeral and humeral ulnar ligaments are pretty much gone. The only one you may have left would be the annular ligament around that radial head. You can imagine with contraindication, we have actually going back real quick. Our outcomes are actually pretty good because we're picking the right people for this. Generally, again, if you don't fit one of those other indications that I kind of mentioned before, they generally don't do an elbow replacement with you. And some of our contraindications for doing this, well, absolutely kind of with everything else, we won't do surgery on anybody that has an active infection. If there's ankylosis, like it's fused from a systematic disease, if you will. If there's this very, very, very severe contracture, or you don't have enough muscle function, right? If you have inadequate muscle activity, why would we replace it? And some of the relative contraindications would be more chronic instability, again, because remember, we're going to make them a little bit more unstable by doing this. Heterotopic ossification, we know that if we don't want that bone to develop in things that it ain't supposed to be developing in. Dysfunctional hand, if you can't really use your hand anyway, I don't know why we replace your elbow as much. Or if you're that younger patient with the higher demand, we kind of talked about why that was already. Interesting thing about kind of the development of the total elbow replacement, if you will, is it was originally it was only a hinged kind of joint. You're like, oh, the elbow hinges, that makes sense. We'll kind of do that. And so when they did just a hinge joint, everything else was straight. We actually saw increased loosening, and the metal actually would wear out. So then they actually started to add about 5 to 10 degrees of varus and valgus, as well as a little bit of rotation. And the reason they did it is they found that the prosthesis would just last longer and the patient would be able to function better. And then they could do what they called a linked or unlinked or semi-linked. And the semi-linked is the most common, about how much articulation is there between the two pieces. So what they actually will do, and this is what I'm kind of talking about, is you'll notice that on this picture on the right, that where the stem is, you're going to see that kind of the top stem, as it gets into the ulnar side, you actually notice the stem kind of shifts towards the middle side of the picture, and then it bends and rotates a little bit that way. So it's trying to give you a little bit better true what the joint will do as it goes through its motions to help make that prosthesis last a little bit longer. And so the reason that they would do this stuff is generally the procedure. Usually you're going to go through the posterior side of the olecranon. The triceps gets detached or spared or split depending on what they're able to do. Or the joint is dislocated. They may resect the radial head anyway if they're trying to create more space in there. So again, the thing that we really need to know is I want to know, something we saw with the shoulder replacement is I need that surgeon to tell me what was the range of motion they had right after there, because that's as much as I'm going to be able to get them back. And we kind of talked about already is I'm not going to try to crank them to get more and more and more, because the more motion I give them, the more unstable I'm going to make that joint. And it's usually the instability of the elbow that leads to the failure of the prosthesis or the patient being able to use their arm. So post-operatively, we have to make sure we're really looking at there's going to be some triceps insufficiency, because they may or may not have had to detach or split or spared. If they detach it and then reattach it, we know that it's going to be a longer rehab. If they just could spare it, if they could push it to the side, we know it may be a shorter rehab. You may have to watch out for loosening if you start to make them move too much. There's going to be a period of mobilization for this. There may be a fracture. You got some metal in there now, so it could twist the bone in a different way and create a fracture. And then, of course, you have to watch out for your infections. So watch out for those warm, swelling, hot, redness, doesn't look good kind of visual things you may see. So just make sure you're always checking out patients and you're looking at their wounds and looking at their dressings whenever you can, even in the outpatient setting. So continuing on here with the total elbow replacement as well, when we're doing the management, we know we're going to go through that protective phase. We're going to have that period of immobilization. We really want to make sure that we are protecting it the best we can. So this is one, if you think about it, right? If we had to detach the tricep and then reattach the tricep, the position of immobilization is going to have to be with the elbow straight, because we need to put that triceps in the shortened position. So you may see slightly different mobilizations depending on if the tricep was spared or if it was resected. So that's why it's always important to know what kind of happened in the surgery. We know in our max protection phase, we're really working on controlling the inflammation, we're controlling the swelling, we're controlling the pain, we're trying to control wound care. We want to work on early range of motion. Um, if it's we can work on some active range of motion. If there was more instability that kind of happened, if they had to cut through more things than they originally thought, we may delay the motion a little bit more. We want to maintain other ranges of motion, so the best of our ability to maintain what the hand can do, maintain what the shoulder can do. That way we can minimize disuse and atrophy. And then if the we have it's also when you have if you had that, we kind of talked about the unlinked versus linked versus semi-linked, that adds to a level of stabilization. So if it is unlinked, if the prosthesis itself is unlinked, it's more unstable, meaning that there's going to be a slower rehab. There's reasons that one would be chosen over the other in your book. We'll talk about that just a little bit. In that moderate protection phase, that's usually about 4 to 6 weeks later, and the reason for that, right, that's our bone healing time. Now the bone has calloused around the metal, so we're not going to loosen that hardware nearly as much. And this one usually lasts around an additional 12 weeks because we're trying to let everything kind of get stabilized. So we're working on to improve range of motion and strength. There's going to be a permanent lifting restriction of about 5 pounds. Again, it makes sense when we talk about that because, again, with the surgery, you don't have a lot of ligaments or anything else stabilizing the elbow, so you don't want too much force that would then destabilize what is left of the elbow. Joint moves may be inappropriate after this, particularly if you have a linked implant or if stability is questionable. So again, makes sense there, right? If I'm talking about how all those ligaments are and the joint capsule has been cut through, why would we do joint mobilizations on this patient? There's no capsule to stretch. There's no ligaments to stretch at this point. So you wouldn't necessarily be doing any joint mobilizations on this patient. So even in the maximum protection phase, maybe we're not doing grade 1 or grade 2 joint mobilizations. This whole point was to improve the surgeries, to improve function, and to do the best they can. So we're gonna not necessarily worry so much about the range of motion because we don't want to jeopardize the stability of the joint by making it too mobile. We'd rather give up full elbow extension or full elbow flexion and not work on those things if that allowed the patient to maintain their stability of the joint to the best that they have left. We may use things more like low intensity manual self-stretching. We're going to make sure we're using those kind of long loads, low loads and long duration kind of stretches because everything's been immobilized for quite some time. And we're definitely going to work on extension prior to flexion. And so the reason you can think about this again is what they had to do to the tricep. So I'd rather not stretch the tricep by going into flexion. I'd rather get into extension. Additionally, that extension is a much more, we need that a little bit more when we think about pushing the door open or standing up out of a chair or any of those kind of things. We need more elbow extension than we do flexion. And the procedure itself went through that posterior capsule of the arm. So remember, flexion is going to stress out that posterior capsule. So we stick with working on extension first to protect those areas that had just undergone the surgery. And then we have to be careful for a little bit of ulnar nerve problems because, again, we went to the posterior side of the elbow. We know that nerve lies posterior to the elbow itself. And then patient's not going to be able to do things like high loads or racket or throwing or golf sports, right? Because that's very fast speeds with a joint that's relatively unstable already, and that's just going to increase the stability. So it's having that patient education you may have to do with them. Our outcomes, our pain relief that's usually the number one reason people are getting this, and we're pretty good with that. It looks pretty good. A range of motion you're kind of looking for. You take this with a grain of salt, alright, but most of the time you'll see 15-ish degrees lacking of elbow extension, and then flexion will be about 130-ish degrees. Pronation and supination are also going to be affected because of where that prosthesis goes. So with pronation, you're looking about 68 degrees, supination about 62 degrees. So this patient, it's not appropriate to write goals of restore full range of motion compared to the other side because we're not expecting them to get there. If we did, we may compromise the whole point of what the surgery was. If we look at functional activities, like what do we need to be functional, we need about 100 degrees of an arc, if you will, of elbow flexion. So if we can usually operate, if we're missing 30 degrees of elbow extension, and if we can get up to about 130 degrees of elbow flexion, that's a 100-degree range there. That's usually okay. We can do most things that we need. And with pronation and supination, 50-50 is usually the things we need for most functional activities. So for this patient, those would be much better goals to write for them than it would be to say, let's restore, pronation and supination to 80 or 90, or elbow extension to 0. So you have to consider the patient that's in front of you. With our survival rates for these, we know that joint replacements don't last forever, but we do know they'll survive longer if you don't do a whole lot. So if you have low-level work, or if you don't do a whole lot of things recreationally, you have less chances of destabilizing the rest of the surgery, and so then your outcomes usually are longer and better. If you decide you want to do the other things, such as going back to golf and throwing and racket sports, then usually those people's prosthesis doesn't survive nearly as long. So, I think I messed up here on the slide. Boom. Okay, we can do this. Ha! We'll make it work. So this one you can have, you can also develop, one of the complications could be myositis ossificans, or this can also happen by itself, doesn't have to happen post-surgical, but basically with myositis, muscle, itis, swelling, ossif, that's bone, ossificans development. So we have formation of bone in an atypical location of the body. It's synonymous, not synopsis, it's synonymous with heterotopic, which we already talked about, or ectopic bone formation. Um, how this kind of happens is it's relatively high after trauma. We kind of talked about this a little bit. Like you can have it. There's evidence that will say it's high as about 40 after an elbow fracture. It's about 40% chance you'll develop this. It's definitely most common at the posterior medial aspect of the elbow. And nice part is, or there was a little bit of thought that maybe we were creating these things in physical therapy, because they generally will show up like 2 weeks after injury, and so people thought we were doing things. But there's no evidence that overstretching or participation in physical therapy contributes to this heterotopic ossification. How patients usually will kind of present with this is they're going to be this palpation of like a locking sensation at terminal elbow flexion or extension. So if you guys recall with some of the subjective questionnaires, we talk about clicking, popping, locking, catching, because if patients are using those words, it should kind of trigger our brains to thinking different things. It doesn't sound quite like it would be a normal thing. It could be we need to ask more questions. As I mentioned before, it generally begins about 2 weeks after the injury itself. With the kind of observation, you're going to see some swelling, some warmth, and some pain, and so you're like, oh my gosh, that sounds like an infection. Well, that may be if you're looking at somebody who's got post-op surgical, we're thinking of that nature. But if they didn't have a surgery and they're still having this warm and swelling and pain, and they're complaining about this trauma that was there before, this may be an indication that this is kind of developing warm swelling and pain, because remember that muscle, that bone is starting to form. It needs blood flow, and it's going to create inflammation. So that's what starts it. That's why it's swollen and warm. And you're going to notice a gradual loss of range of motion of the elbow. So if I'm working with a patient and we're working on some elbow range of motion, every time they come in, even though we're stretching and doing joint mobilizations, we're seeing more and more and more loss of range of motion. Well, that I was trying to treat that and it's not working, so usually there's something else going on, and this may be the case of that they're starting to have that bone formation, and you're not going to get that same flexion. This would be another case where as you go into that motion, you're going to get that hard end feel, right? You got a bone that's stopping you now. You're getting bone on bone resistance. So remember to always reassess what your end feels feel like. And basically what happens with this is the bone is going to get laid down in the muscle, between the muscle fibers, kind of around the joint capsule, which makes the muscle extremely firm to the touch. So your palpation, you can generally identify these things because you pinch it and you're like, wow, that does not feel like a muscle at all. That feels more like I'm pinching a bone. With management of this, oftentimes this actually, if we can, this will actually get reabsorbed. If we do not create the stimulus of compression, the body will start to say, hey, wait a second, we don't need bone here. We can start to reabsorb it. So, but it takes a while. It'll take about several months. and then afterwards motions are usually returned relative to the normal. We're looking at in the elbow here, but if you can imagine places that are getting hit all the time with direct compression, those are the places that generally form. So arm and humerus is kind of one from the fracture side or falls. In the NFL, running backs will actually get this in their quadricep a lot because they're always getting hit in their legs. So when people are like, oh, I don't need to wear knee pads, that's when I kind of just shake my head and say, okay, but don't be surprised if you start losing some of your range of motion, or you're like, man, I feel this knot in my quad. I'm like, that ain't a knot, that's a bone. Um, Other than that, you may use things like prophylaxis, use of NSAIDs, right? Those non-steroidal anti-inflammatories to try to cut down on that inflammation and bone development. You can use some radiation therapy. There's some thoughts that maybe getting like pulsed ultrasound will kind of break up some of that bone that's in there. And then if it doesn't work, and then you're gonna have to get surgery, and they go in and they cut it out. And so then we don't want that period of immobilization as much, because if we do, we may simulate that bone growth again. So what they do is usually putting on one of those continuous passive motion machines in order to keep the muscle moving and not allowing that bone to develop in the first place. So kind of moving on to the overuse syndromes and repetitive trauma syndromes. These are ones you guys are probably more familiar with when you're thinking about tennis elbow or golfer's elbow. Those are just based on which side is involved. Are these flexors or extensors? Remember we talked about that earlier. So when you hear the term tendonitis versus tendinopathy versus tendinosis, what is the difference? Well, we both know we all know that the first part of that, tendon, means that it's happening in the tendon itself. Itis meaning it's in the swelling phase, right? It's an active inflammatory thing going on. Apathy generally means it's more in the subacute or chronic, where there's not really any more active inflammation happening. And then tendinosis, that generally means it's been degenerated in the chronic phase for quite some time. So you have to really be careful when you're using these things, because people will call these, how long have you had this elbow pain? Oh, I don't know, 3, 4, 5, 6, 7 months. And then they're like, oh, you have elbow tendonitis. Well, that's not true. You wouldn't have it at that point unless you just recently flared it up for some reason. So part of your evaluation is to go figure it out, because if it's in the itis, I got to treat it as if it's in the acute phase. But if it's an osis or an apathy, then I can generally treat it as if it's in the subacute or the chronic phase. So I could be a little bit more aggressive at first, which is nice. So we know that tendonitis, right, that term does not accurately reflect the true pathology if something is more degenerative in nature rather than the inflammatory process. But people use that term all the time. We know that when you have degeneration, if it's in that chronic phase, we have some dysfunctional vascular function, and we have fibrous tissue and disorganized collagen. So we're in that kind of chronic phase where things haven't been laid down appropriately. We just got everything all over the place. So when we look at the lateral elbow tendinopathy, remember that goes with more of that tennis elbow, and it's usually more of an extensor problem. There's generally pain over the lateral elbow, particularly with anything that involves using your extensors. So we know with grip, to get your grip to be stronger, you'll generally see the wrist go into extension. We may see some firm wrist stability activities that are problems, such as the backhand of a stroke. So that's where people get it from. You use backhands a lot. That's where you're hitting the ball and your extensors have to kind of fire to keep your hand and wrist stable. But that's where the term tennis elbow came from. But you'll get a lot of people that have never played tennis in a day in their life, and they get this. So tennis elbow has become a bucket term for what this is. So if the patient's not complaining of this during tennis, I generally don't tell them it's tennis elbow. I'll generally, because they usually Google and say, it says I have tennis elbow, but I've never played tennis. And then I just smile and say, yeah, I think you actually have more and more of a lateral elbow tendinopathy. And then they're like, oh, okay, it sounds different. So that makes more sense. You could also get it from doing repetitive tasks that require wrist extensions, such as working on the computer, typing, if you're not in an ergonomical position. Wow, that's a harder word to say than I thought. And then, other than lateral elbow pain, you may have had something where it pulled on your elbow too much, or pushed on your elbow too much, or you may have more other things that can create that, or lateral elbow pain could be radial head osteoarthritis or radial tunnel syndrome, or even going back up, we talked about that cervical root compression. So if somebody shows up with lateral elbow pain, those are all the things that you have to kind of figure out, knowing that if it's a tendinopathy, they won't be complaining of numbness and tingling because that would match up with a nerve. So we can kind of get rid of radial tunnel syndrome or cervical root compression. Is there a loss of range of motion? That may potentially be more something of um, radial head osteoarthritis. And would radial head osteoarthritis get worse if I did repetitive gripping activities? I don't really know. So you can see how you can start to put those things together and that subjective nature prior to actually having to even touch a patient's elbow and start to figure out which one you think is most likely. When we look at the medial elbow problems, we're looking more along the flexors. Well, let me go back here actually because I think I have a nice picture for the extenders. Yes, I do. Perfect. So this is when we're looking at those extensors here. We know that the extensor carpi radialis brevis is usually the most involved one in this kind of pathology. So we'll actually show you in MSK next year a little cool manipulation for people that have this discomfort, which is fun, down at the wrist. But again, we kind of looked here in that repetitive trauma. We're seeing it in the tendon, we're kind of getting these micro tears. So maybe this is kind of that grade 1 tear that we have, and it can get a little bit more when we get into that grade 2 different tear and that extensor problem. So that's just kind of where the patients usually kind of complain of pain, and you can usually palpate that directly, and you can stress it differently to kind of reproduce their symptoms. Remember, that's the goal of an eval. We got to be able to reproduce the patient's symptoms so we know what's going on. Going back down to the medial elbow here now, we know that's more of the flexors and the pronator tendons. And they usually, again, the pain will usually kind of show up in this tendon muscle junction like the extensor one did. This one, usually the mechanism is more repetitive wrist flexion, such as pitching, grasping things, lifting heavy objects, playing golf would be another one. The idea on this one was when you go to swing, if you hit the ground, your elbow goes in a little more valgus position. That valgus force stretches those medial flexor tendons and muscles, and that's what can create the discomfort. So that's where the golfer's term came from. And there's pain usually with active wrist flexion or passive wrist extension. So remember, you can kind of use those things of if you think it's a muscle or a tendon, generally resisted active range of motion towards that way is uncomfortable. So if it's a wrist flexor, resisted active wrist flexion is uncomfortable. And then active wrist extension is not uncomfortable, remember, because patients generally will guard themselves and not go to where it hurts, versus passive wrist extension would stretch all those things and it becomes uncomfortable. So we actually use that, and when we get to MSK, of trying to figure out, does this sound more muscly, more tendony, more ligamenty, more something else? And we know with the symptoms, the most common cause for either of these things is really repetitive strain or eccentric strain. You're trying to you're creating micro tears in there by contracting and elongating. So that eccentric strain is what kind of brings some of the tears down. And the more that we do that, the more we start to weaken that collagen. And so basically what ends up happening is we show up with a decrease, our grip strength starts to decrease. Our spine may not move as much anymore because we're trying to protect our arm. We may have weaker shoulders, and that's what's putting more stress on the elbow itself, or we start having weaker shoulders because of disuse, because remember, these are generally chronic problems. And then we have a lot of tenderness to outpatient for sure. And patients are usually complaining that they can't get back to some of their activities they were doing before, such as playing tennis or playing golf or typing, just sitting at the computer, gripping things like using a hammer or a screwdriver. So your folks that are in more manual labor activities, they'll often have these kind of pains as well. So you have to kind of use those things, and that may be some of the limitations they have and some of the good goals you can start to write to help this patient get back to where they need to go. Oh, I already covered all those things. Man, I'm on top of it. Excellent. Moving on. When we get to looking at how we kind of treat these things, most of the time we're treating these folks non-operatively, and so in the protection phase, we do exactly the same as we've done for everything else. We decrease pain, we decrease swelling or effusion. We maintain function to the best of our ability. So immobilize when you need to for protection. Use chirotherapy if you have to. Relative rest, right? Relative rest of the tissue that's involved. We can still do other things. We could do active range of motions for things that we can do active for. We could do passive range of motions for things we can do passive range of motions for. We can work on shoulder. We can work on hand. We can work on back muscles. We can work on posture. We can work on ergonomics. We can do all these things in this protection phase depending on why you think the patient is presenting the way that they are. With the more degenerative problems, right, so this is not an itis. This is usually more of an osis. We may find that we can start to be a little bit more aggressive because we don't have to really protect things as much. We can do things like soft tissue and joint mobilizations a little bit more aggressively. We may start here. We may start some cross friction massage, and again, that extensor carpi radialis brevis is generally the one that does the lateral elbow pain the most. So we may actually do cross friction massage there. And while they're doing that, we're having them lift their fingers while we're palpating the dorsal head so we can figure out which one is the extensor carpi radialis brevis and do cross friction massage from there. We may work on some neural flossing if we think it's more of that nerve entrapment. We could do some soft tissue mobilizations. We may do some isometrics, the whole relaxant things. We may do some passive stretching. Again, you just have to look at what the patient is in front of you. Are they truly in the acute phase? Are they in the subacute phase? Are they in the chronic phase of tissue healing? And then in the rehab, what do we need to do? Do we need to rest things? Do we need to protect things? Are things fully torn? Are things partially torn? Is this just more degeneration? You have to adjust your plan of care accordingly. Moving into the controlled motion and return to function phase, we know we've got what our goals here are. We want to increase muscle flexibility, restore joint tracking, particularly of the radial ulnar joint for these patients, and improve muscle performance and functions, and really work on patient education. So for the flexibility standpoint, we can get that by manual stretching, stretching them, self-stretching, them stretching themselves, working on some cross fiber mobilization as well, soft tissue mobility. With the joint tracking, we kind of talked about already, we can do a lot of mobilizations with movement. So what this basically means is that I am going to provide a mobilization of something, and rather than do my oscillations, I'm going to hold that mobilization where it is, and then the patient is going to actively move through different things. There's some nice explanation that you have in your book about how to do this, and we'll do a little bit more in lab. And then patients, if that's successful, you can actually teach them how to do some things at home using straps or the doorways or use their own hands, which is really cool. For muscle performance, again, if you're thinking about these repetitive traumas, most of the time they're in that degenerated tissue, more in that chronic phase of tissue healing. And so we may use things such as like an elbow strap. You guys have seen people wearing these things around the elbow. What the point of the strap is it takes the origin and insertion and changes them to change the line of tension. So now instead of the same tension going through the whole thing, you change where the line of tension is. So it's usually there to help patients' pain, and when the pain is reduced, usually you see an increase in strength from the performance. It's only a temporary fix, but if a person has to play or they're not listening to you anyway, and they're going to do it no matter what you say, may be something that you may use. You may have heard the term Chopat strap. That's usually what those straps are kind of called. You may have also seen people running with these around their patellar tendons, because you can do the same thing with the patellar tendon. Working on the muscle performance, again, it's usually more of a tendon. So in order to work on tendons, we know tendons love load. So usually the exercises you'll work on are more of the eccentric exercises. They're usually somewhere between a 6 to 12 week program, depending on how chronic the injury is, and you're doing somewhere about 3 sets between 10 to 15 reps, nice and slow. And you're also going to work on some speed stuff, because when you think about typing, it's not really a slow motion, it's faster, or using a hammer is faster, or playing sports are faster. You got to do some plyometric training as well. And then activity modification is another good one. What do we need to have them modify in order for them not to flare up their symptoms as much? And some interesting thing about this with some of the evidence that we have is basically like 8 weeks of treatment, and at a 6-month follow-up for lateral elbow pain, we had about 80% improvement for most of our patients, and only about 33% of those people that had improvement actually had complete resolution of symptoms. So you're talking about patients that, again, maybe pain-free, particularly if they've had this for quite some time. Maybe pain-free is not the goal. It's let's do more with less pain. And also, that was after 8 weeks, and we know that some of these programs run for 12 or more weeks. So kind of setting your patient up for success, letting them know, hey, you've had this for a while. It's going to take a while to kind of get away. And what this treatment was, and from this evidence, again, I like using numbers because I'm a numbers guy. But if you look into the literature a little bit more, they'll talk about how some of the treatments involve using an ultrasound, friction massage, strengthening, and cervical spine treatment. So they even though they work on the elbow, they add in the cervical spine because we know that can refer down to the elbow as well. So here's an example of that mobilization with movement. The patient is providing a lateral glide of the elbow, and then the patient's going through active wrist extension, and they're gripping that dynamometer because they have to keep the pressure while they go into those active motions. We'll actually go through some of these in lab, and there's a nice kind of exercise progression of doing about 6 to 10 of those, building up to 3 sets of that 10 with resisted extension. And this actually, I do this with patients that I have, and I find it to be very effective. All right, moving on to exercise interventions for the elbow and forearm. What you guys came here for? I get you. So let's get into it. So we know we have a lot of exercise techniques to improve flexibility and range of motion. I'm pretty sure you guys have seen these things. We talked about knowing what's going on. The key things I want to point to you are you have to look at active, you have to look at passive, you got to see what your end fields are. You got to do them. If you don't do those, you have no idea what you're doing. If you are working on elbow flexion and you get to 100 degrees and you have a hard end feel, you probably need to send this person for imaging because we got something that's going on, if especially if they've had a trauma recently, because that could be that heterotopic ossification. If a patient has, maybe they're missing 15 degrees of elbow extension actively, but passively you can take them and they get all the way down to 5 degrees of real extension with a normal hard end feel, then we're good, right? We don't need to stretch this person. We need to work on some other things instead. So you really have to, and then you just have to make sure that joint capsule is not always the restriction. So there's a difference between capsular end feel and muscle stretch. So you have to check those. If it's a muscle stretch, stretching is going to be awesome. If it's a joint capsule end feel or that capsular end feel, then you're going to have to do some joint mobilizations instead of just stretches. So if we're looking at limited elbow extension, we know that passive elbow extension is going to be limited by your flexors. That would be your biceps, your brachialis, your brachioradialis. So those muscles all do a little bit different stuff other than just flex. So we need to work on elbow extension, and we need to have our hand in pronation. We need to have it in kind of mid-range, and we need to have it in supination because all those muscles, it's going to target all 3 of those different muscles depending on which position that you're in. In addition to that, if you think it's the biceps that's limiting you, you better have them in shoulder extension because that will actually stretch the biceps out from the top and elbow extension. So if you really think it's the biceps, you got to have both shoulder extension and elbow extension. Otherwise, you're not really targeting the biceps specifically. If they're missing elbow flexion, that can generally be the long head of the tricep. So you guys remember from Tests and Measures, we did the behind the back test or the Apley scratch test looking at range of motion. Well, this is an indication that arm that's going up and over your head trying to touch your other shoulder blade. Sometimes it's the long head of the tricep that's going to limit shoulder flexion and elbow flexion. So you can use that to your advantage and figure out what kind of stretches would be better for this patient. And then to increase forearm pronation and supination, it's the same idea. We know that the pronators will limit passive supination, the supinators will limit passive pronation, and then depending on which position that you're in, we know the brachioradialis may limit pronation or supination, depending on. So you have to kind of look at that, and your book actually does a really good job for this section of kind of showing you some pictures and kind of outlining what they're talking about. So if you're having some confusion about what I'm talking about, take a look. There's a lot of really good pictures in your book for these things. We know patients can do self-stretching of the muscles, particularly if we think of the elbow here now. We're talking about the medial and the lateral epicondyle, the muscles that attach there. So remember, the medial side, you have the flexors attaching there. The lateral side, you have the extensors stretching there. So really, in order to stretch those wrist extensors, if you're looking at your arm, if you're in that pronated position, you know that everything is a little bit more laterally, but then a lot of those run a little bit more medially, even towards your thumb. So to stretch those extensors, we really need to get into wrist flexion, pronation, and ulnar deviation. That's what's really going to stretch out a lot of those wrist extensor muscles. Check it out for yourself. Hold your arm out straight. Go into wrist flexion. Go into pronation and ulnar deviation, and then stay in wrist flexion, but go into supination and radial deviation, and you'll see just the change in the type of stretch that you have. And then you do the opposite for the wrist flexor muscles. If you're trying to stretch those wrist flexors, you need to go in wrist extension, supination, radial deviation. Use your anatomy to your advantage. We need to develop and improve muscle performance control and add in and keep things going, which is what you guys, I think you guys have figured out, the isometrics. I definitely undervalued when I was a student, for sure, and when I got out for the first couple of years. And then the more I practice, the more that I use them, because they just seem to help with pain, swelling, range of motion, strength. It was too many bangs for my buck for me to ignore anymore. So you can use a lot of isometric training in this kind of patient population. You can use heavy resistance, light resistance, depending on what phase that they're in. You can do multiple angle isometrics. I can change where I am. We can do angle specific training, which is really cool. So what is this patient trying to do? How can I replicate that? And the reason that's so important is because strength is specific. And depending on how we strength train it, it's how we'll get better. So what I mean by that is you can use like a leg press, for example. If I can leg press 1,000 pounds, then in theory I should be able to stand up and squat 1,000 pounds, but I can't because it's different kind of training. And just because I can single leg squat so much, it doesn't mean that when I get and do a jump, it translates over there, because it's not the same kind of strength. So you need to replicate not only the positions that you want people to go into, utilize the muscles they want into, you also have to replicate the speed that people have to get into. So that's why those higher end rehabs, they talk about trying to get some of that power back, because you got to be able to get to whatever it is that this patient needs to get back to. And then you can always do your alternating isometrics and rhythmic stabilization things in open or closed chain. So quadruped is a great place to start to work on that kind of closed chain rhythmic stabilization. The elbow is very similar from, if you work with me here for a second, in closed chain, the elbow, if you compare the leg to the arm, the hand would be similar to the foot, the wrist would be similar to the ankle, elbow similar to the knee, shoulder similar to the hip, if you can get what I'm saying. The knee and elbow are both hinge joints. So you guys have seen a lot of cool rhythmic stabilization stuff with the knee, where people take the hands and they pull their knee in, or they have them pull their knee out, or they're kind of putting their hand on one and then going to the other side. You could do the same exact thing to the elbow with a patient who's in quadruped. So you can use quadruped a lot to increase stabilization, and we know that's really the function of the elbow, is to stabilize. So a really good place to do that, and you can do it in open chain as well. With the angle specific training, I want to go back here as well, because we talked about doing that carrying angle, that people have those things. There's a normal amount of valgus the patient's going to have. So in order to simulate the use of the elbow for returning to functional activities, like carrying large boxes close to the chest, well, that's generally in about, not only am I in a little bit of valgus, but I'm also, with the amount of elbow flexion that we have, usually it's about 70 to 90 degrees of elbow flexion that people will carry things into. So if I'm working on quote unquote bicep strength, I like to have people hang out about that 70 to 90 degrees of elbow flexion. Not saying you can't work on the zero, not saying you can't work into full flexion. Those are good spots to do too. But when you're trying to think about returning to functional activities, most people are going to carry boxes or heavier things around that 70 to 90 degrees of elbow flexion. When we're trying to get into the more performance and functional control things, we know we need to work into dynamic strengthening and endurance exercises. With the elbow flexion, remember with elbow flexion, we know we can work on wherever the forearm is. That will dictate what kind of muscle we're using. If it's fully supinated, we're going to get more bicep. If it's in that mid-range, we'll get more brachioradialis. If it's in that pronated forearm position, we'll get more brachialis. So which of those elbow flexors do you like? And then with that shoulder position, remember the only one of those muscles that across the shoulder would be the biceps brachii. So if you want to work that a little bit harder, you can always get into a little bit more elbow extension. Or if you add in, let's say you do a bicep curl and then go into shoulder flexion, now you're going to add in a little bit harder work for that biceps. That's why you see, actually that's a good point. I was just reading something, sorry. Like you see people in the gym is they'll do bicep curls, but they're going to do them with shoulder extension, and that's because it isolates down the bicep. That's a good visualization. I like that. See, your book has a lot of good stuff. Actually, has a bunch of good pictures here, like figure 18, 11 through 16 have really good pictures of developing strength and with different things to kind of fill through this elbow extension, long head of the tricep, pronation, supination, wrist flexion. So I'd refer to your book because they actually have some decent pictures, and if you can get the principles of those, then you can adapt them and kind of come up with your own if you'd like. And then kind of working our way back to the functional progression of the elbow and forearm is you got to remember that it's not just flexion extension. We already talked about how there's kind of those spiral diagonal patterns. As you go into extension, your elbow is going to go a little more valgus. As you go into flexion, your elbow is going to go a little bit more varus rather than just straight up and straight down. So you got to use that to your advantage. You can start combining pulling motions and pushing motions, and that would be, pulling motions. Like a bicep curl would be a pulling motion, but then a row would be a pulling motion with pulling with your scapular muscles as well. Same thing with pushing. You can adjust. Plyometric training, the short stretch shortening drills. So if you guys aren't familiar with the stretch shortening cycle, basically what that is I can preload my muscles by quickly going in the opposite direction. So what I mean by that is if I'm going to do a jump and I'm going to jump for as high as I can possibly go, you'll notice that with the arms and the legs, you quickly pull yourself down into a squat and then you jump up. And so what that pulling yourself down does is it preloads all your extensors very, very quickly, makes them very, very like spring-like so that they can use that extra stored energy and then give it to you. Versus if I go really, really slow and I do like more of an eccentric contraction down into my squat and then try to jump, I will not be able to jump as high because I have not used that stretch shortening cycle. So if I have athletes that are going to be doing high level things, or if I just have people that go back and they want to play recreational football or play softball league or something, and I know I need to get a little bit faster, you have to do a little bit of plyometric training. And then simulate tasks and activities. What does this patient need to get back to? How can I set that up to the best of my ability? Again, your book does a really good job at setting some of these up, like using a lawnmower would be a really good example. But your book has a really good explanation and pictures of a lot of these things, and you can find those in figures about 18.17 to 22. And that's it, guys. That's it for the elbow. Not nearly as bad as the shoulder, right? There's just not as many things that are different. The key is with the elbow, it's really meant for stability. So you'll notice that any of the pathologies that kind of rob me of my stability, that's usually when if we get surgery, we may kind of not necessarily worry as much about getting our full range of motion back, just enough to be functional. We can have a lot of overuse injuries here just from the fact that we use our hands all the time, and we use our wrist flexors and wrist extensors, and the more we grip, the more we grip and twist, the more chances we have of having some problems here. Most people are coming to you with kind of those overuse symptoms. It's not usually acute. It's usually more in that chronic stage, which means you don't have to be in the protection phase for nearly as long. But they're usually degenerated, so your rehab ends up being, how can I regenerate this tissue a little bit more? And that's why, if it's a tendon thing like golfer's elbow or tennis elbow, when it's that tendon that has become degenerated, that's why people will usually use eccentrics, and you see those used a ton as we go through here. And then in addition, I know we're not in MSK just yet, but as we kind of talked about, one of the common things that refer pain to the elbow is the cervical spine. Same thing we kind of saw on the shoulder. One of the common things that refers pain to the shoulder is the cervical spine. So just because a patient walks in and says, hey, my elbow hurts, doesn't mean you can't do a good job and do your assessment to make sure it's not coming from somewhere else. And if you just do your quarter screens, that's usually what will help you figure that out. And then if you take good subjective history, it will help you get there. And this is always when people will come in like, oh, I got tennis elbow, and I'm like, well, that's an overuse thing. What do you do? And they're like, I don't really do anything. Well, I'm like, that sounds more underuse. So I really like this cartoon because it's like elbow macaroni syndrome. That is great. That is great. If you don't use it, it goes the other way. So, all right, guys, in lab we'll have some fun. We'll work on some mobilizations with movement. We'll work on joint mobilizations again. We'll kind of talk through some of the strength and conditioning principles and come up with some exercises. So, next time I'll see you we'll be on the wrist and hand. I can't wait. I'm super excited. All right, see you guys soon.